Hi, everyone. My name is Shruti Kaushik. I'm one of the associate professor at Mount Sinai Kravis in New York. Welcome to the webinar, and thank you for joining us. First of all, if you use this QRS code, it should take you to the YouTube link for the Pedi ECMO Education Committee, where you can find the previous webinars, and also the recording for this webinar will be posted on this link eventually. Everyone who has a cell phone, the number to text is 713-903-7277, and you can please send the attendance code. We will also add this to the chat, so you can send this later. We are very excited that we are able to offer the CME credit for this, so hoping for the attendance. So first of all, I would like to welcome our panelists. We have Dr. Ellie McMichael, who's the Associate Professor at Phoenix Children's University of Arizona College of Medicine, and also Dr. Giles, who is Professor of Department of Surgery at University of Florida, Gainesville. Both of them have done extensive work with the use of Bivalirudin, and we are hoping to ask them some questions which will help us bedside. So the learning objective for this activity is to review the current landscape of Bivalirudin use in neonatal and pediatric ECMO patients, to discuss the recommended dosing and therapeutic monitoring regimes for Bivalirudin infusions in neonatal and pediatric ECMO patients, to describe the advantages and disadvantages of utilizing Bivalirudin for this patient population. Most of us would have noticed that recently there have been a number of publications about the use of Bivalirudin use, especially in children, neonates, as well as pediatric patients, just capturing a couple of publications in recent years. So one question that we have is, what has driven the centers to make that switch, and what makes Bivalirudin an attractive anticoagulant? I would like Dr. Pedi to answer that question. What's your experience, Dr. Pedi?
Well, thank you very much for inviting me to start with. I just think it's better for a number of reasons. It's simpler. It is blind to developmental hematological changes. So in other words, when you have a newborn who is congenitally or constitutionally deficient in most of the clotting factors, including antithrombin 3, compared to the normal values which are established in adults, the direct thrombin inhibitors don't care about that. They just work. And I think the most important thing is the way that direct thrombin inhibitors in general and Bivalirudin specifically dissolve clot in the circuit. So we've seen this both in ventricular assist devices, particularly I'm thinking about the Berlin heart, which was not actually a usable device using heparin in single ventricle patients. But as soon as Bivalirudin became available, it made single VAD Berlin support a thing, because it meant that patients didn't have massive stroke rates. So it made it possible. When we use it for ECMO, I think it just works better than heparin, and it's much simpler to use because we can just measure PTT every few hours and adjust it accordingly. So it's really simple to use. It's really effective, and I'm going to go off piece slightly here. When we use it in conjunction with nitric oxide in the sweet gas, which we call SNO, you can get enormous increases in circuit life. And I have a patient on at the moment who's been on ECMO since October last year, and who is running the same oxygenator since January the 9th. And for those of you who watch this in the future, this is going out on the 5th of June 2024. So that's 5 months.
Wow, thank you. Just to add one more thing, please feel free to ask your questions in the chat. Hopefully we'll pause in between and try to capture those questions related to the topic. And in the end, we'll come back to the questions which are left. Dr. McMichael, so considering that we have noticed a lot of literature, just the survey studies which have mentioned that the centers which are using Bivalirudin has increased tremendously. And the literature that we are seeing about the results is lacking a bit because they're older patients. So is there data that describes the current utilization of bivalirudin in this patient population?
Yeah, I'd just like to echo Dr. Peak's thanks as well for inviting us to this webinar. It's a really exciting topic to talk about. And I know it's something that we've all kind of struggled with across the country and really, across all the international sites as well. And I think this is the biggest problem that we're having right now is that there, like you have shown, there's lots of retrospective studies and some systematic reviews that have looked at use of bivalirudin, but we don't have any published randomized prospective studies right now that are comparing bivalirudin to heparin in our patients. And so I think this is the problem in the literature right now, that a lot of us are looking at some really great retrospective studies that have, shown at least for the most part that bivalirudin seems to be at least not inferior to heparin and potentially has some advantages depending on the study when we're looking at bleeding and clotting. But our literature right now is really focused mainly on retrospective and small prospective studies, but nothing randomized to really give us that concrete data about bival.
Thank you. Since both of you have used bivalirudin in your practice, are there any disadvantages of bivalirudin? I would start with Dr. McMichael, if you want to answer.
Sure. So I think the thing that people notice the most about bivalirudin, which is a disadvantage, but also I think you can think about it as an advantage as well, is its half-life. So bival's half-life is about 25 minutes, depending on the age, compared to heparin's half-life of about 90 minutes, also age dependent as well. So it's a really quick on, but also a really quick off. Another major disadvantage of bivalirudin is the cost. Honestly, it's a lot more expensive than heparin, although some studies have looked at cost. And depending on how you calculate the cost, especially if centers use antithrombin or administration, that thrombate is very expensive. So sometimes the cost when you compare need for antithrombin replacement plus compared to bival alone, cost may be about the same. Other disadvantages of bival is there's no reversal agent, so we don't have an equivalent of protamine like we do for heparin. But with a short half-life, I think a lot of us have seen that you don't really need to reverse bival, you can just turn it off. Anecdotally, and there's actually some studies that have done some retrospective reviews looking at this, bival is pretty nicely cleared with dialysis and with plasmapheresis as well. So if you really got yourself into trouble, you could use either of those modalities to clear it faster. Those are and then I would say knowledge. Honestly, we have so much data on heparin. We've been using it for a longer time, and as centers, we're more comfortable for using heparin. And so I think it's just a comfort level, to be honest, right now too, is a disadvantage of bival.
I would agree with most of those things. I think in terms of the cost, though, if you look at the testing protocol that most people have, and I'm going to nail Naga Pupala in a moment, not very good during low flow states because you can get around that. Look at the tests that everybody does when the patient's on heparin. They may be doing ACTs every hour. They might be doing heparin levels. They might be doing anti-10A, all of which are well known not to actually agree with each other. And they're probably doing TEGs as well. And then they're supplementing antithrombin 3, which is ridiculously expensive. When we're using bivalirudin, all we do is a PTT every 4 hours and nothing else. And it's very straightforward to both monitor and use. I think the question about stasis is slightly overblown. I think if you've got a left ventricle that is full of blood that's not moving, then I think it's a real problem. But I think that you can get around most of the issues about blood not moving in your circuit by designing your circuit appropriately. And I think if we all got rid of unnecessary shunts, like the Medline, and got rid of unnecessary bridges, and got rid of unnecessary connectors, you find it works just fine. And I think those are good things to do, whether you're using heparin or bivalirudin.
Thank you so much for discussing that. I think the cost utilization question still remains, considering studies out there have shown that blood product administration and antithrombin might just be enough to justify the cost of bivalirudin. So hopefully we'll have more data. So for the centers who have either switched to bivalirudin or who are thinking very strongly about switching to bivalirudin, the big question remains is how do you monitor bivalirudin? And everybody has question about how do you dose it and what to do. So I want to start with first dosing. In your experience and practice, how do you dose bivalirudin? Do you utilize bolus dosing or just start with a continuous infusion? Dr. Peak?
Thank you. So I still use heparin when I'm going on because, you know, like you said, we have a lot of experience, or rather, Ali said, we have a lot of experience of using it. And we don't have a lot of experience of bivalirudin as boluses. So we still give a loading dose of heparin. And in the situation where we're coming from bypass to ECMO, the patient's already heparinized. So, you know, we don't tend to give boluses. And then we'll start our bivalirudin usually at 0.05, or if we're worried about the patient bleeding, we'll start at 0.03. And then we'll do a PTT in 3 hours, and then we'll adjust it accordingly. And it all depends on how much the patient is bleeding and whether, you know, what the clinical scenario is. So in a patient who's had a lung transplant or, you know, heart surgery or whatever, then we're going to go up more slowly than in a patient who's just got ARDS and a closed chest. And then we'll set our target PTT usually 60 to 80, and then we'll just adjust it accordingly. And it's very gentle and very easy to monitor.
Just one follow-up question. Do you use a different dose for neonates versus pediatric patients, or the same dose?
I think it's the really interesting thing is that the answer is no. It just seems, you know, it just seems to work and be very, very straightforward. We've recently completed, not published yet, a study looking at using AI to predict what the dose is going to be, and that's going to be that's been presented, but it hasn't been published yet. And that's one of our medical students that's doing that. Lindsay Brinkley, and so you're going to see that very soon. So I think that those kind of things are going to be a big thing in the future to allow us to get to a therapeutic level more quickly.
Dr. McMichael, what's your experience with the drug? Do you use bolus dosing?
We don't use bolus dosing, I think, because we found, again, because the half-life is so short, it really doesn't seem to make a difference. You can just start the infusion and increase as you need. I have used it anecdotally in trying to, after plasmapheresis, trying to get a patient back to steady state faster. I will say it did not work. And so I think a lot of the data shows now that bolus dosing is not necessary, and just a continuous infusion is all that you need. I'm a little surprised about Dr. Peak's initial starting dose. I think in our so when I was at my last institution, we did a small randomized study looking at bival versus heparin, which hopefully will be out soon. And the starting dose that we used for that study was 0.15 mg per kg per hour, and we found that we had a hard time getting to steady state quick enough. And so our center here at PCH is looking into starting higher doses, probably somewhere closer to even 0.2 or 0.3, depending on the bleeding risk. And I think that depends on the patient too. So if we're talking about a post-cardiotomy patient who's coming off bypass, who's bleeding from their chest tubes, and definitely I think you're wanting to think about a lower starting dose. But if this is a VV patient who's going on for ARDS, like we may want to, and who has no bleeding risk, then I think starting at a higher dose may be helpful. And I think anecdotally, we have, asked for protocols for centers who are using bival, and it's a really interesting difference among centers about what our starting doses are. It's a pretty wide range.
I think that's a good point, and I agree with you completely that that's the kind of dose you're going to end up on. But I probably need to clarify why our starting dose is what it is. We have this microdose step in our anticoagulation ladder, which evolved from what we used to do with heparin, where if the patient was at risk of bleeding but not actually bleeding very much, we used to run 10 units per kilo per hour of heparin, just like you did for a BTT shunt patient. And we didn't track the PTT. Now, we do the same with the bivalirudin. So let's assume we've got a patient who's bleeding coming out of the OR after heart surgery. We will, for the first 6 hours, not give any anticoagulation at all, apart from nitric in the sweep. And then after 6 hours, we'll start the heparin, the bivalirudin, at a fixed dose, so 0.05 with no titration. And we'll do that for 6 hours, and then we'll go up. So we kind of pragmatically try to simplify our regime. So our starting dose is always either 0.03 or 0.05. But we don't expect to see much of a bump in the PTT, with that. So it does give you a slow onset of your anticoagulation, and you're absolutely right. The dose that you're going to end up on is, 0.3, something like that. So I completely understand where you're coming from, and agree with you.
Based on your review of protocols from other institutes who are using bivalirudin, have you noticed, have people been using different dosing changes based on the pump type?
Oh, it's a great question. I don't know about based on pump types. Are you talking about roller pump versus centrifugal? I haven't seen the differences in that. I think the different protocols I have seen go up based off, some go up based off of percentage and some go off based off of a total dose. And so I think that just depends on the center and what they're comfortable with and what they've done with their heparin patients, and also kind of what they've done on their bad patients too, if they're pulling some of their protocols from the Action Network. But I haven't seen a difference in pumps, and that's, primarily here in the PICU, we just use one pump type.
And one more follow-up question. The published data so far only captures that centers have been using heparin for bolus and bivalirudin. After that, are you aware of any center that uses bivalirudin to prime their circuit, or anyone that has considered that?
I'm not aware of any center that does that. Dr. Peak, I don't know if you know differently. I think he, stated really correctly that right now we don't have, I think, enough data to know what we should be doing for our bolus dosing immediately on, and it's probably not worth the risk unless the patient has HIT. I think it makes sense to bolus with heparin and then start with your bivalve infusion. So I don't know any centers that immediately start with bivalve from the start.
I agree. I think this is needs a bit of research, and it would be very easy research to do. So you should delegate it to your fellows, Shubi.
I will, thank you. Thank you so much for answering the question about bivalirudin doses. Dr. Giles, is there any question in chat that we need to ask about the dosing at this point? Or anything that we need to capture before moving on?
Questions coming up about bival with trialing off, lab testing and monitoring with bival, and then a question on fibrinogen. I think these will come up in our PowerPoint. So
great, thank you.
Can I? I've got to go and deal with the patient. Can I just address the whole trial off thing?
Yes. So the big question is, how do you trial off ECMO?
So the trialing off issue depends on how you trial off. So you can do clamp trials on with bivalirudin perfectly well, and you can clamp the arterial cannula for 10 minutes perfectly safely. However, do you need to? So why do a clamp trial? You don't actually need to do a clamp trial. It would be far better, I argue, to do a pump-controlled retrograde trial off, and then keep the blood flowing the whole time, and then you don't have to worry about it then. And for those of you that are not up with what a pump-controlled retrograde trial off is, it's described in the 6th edition of the Red Book in the neonatal trial off chapter. But very briefly, you basically turn the RPM down until it balances the flow, and you've got zero flow. And then you turn it down a bit more, and then the blood flows backwards around the circuit. And so it never stops. It's very easy to do, and it gives you a much lower instance of the circuit clotting. But you may have a situation where you can't do that. For instance, let's say you had an older patient with a femoral venous drainage cannula, an arterial cannula in the femoral artery, and a distal perfusion cannula. In that situation, you could clamp the arterial cannula, keep the distal perfusion cannula flowing, at just 100 mils a minute or something, and then you could flash the arterial cannula every 10 minutes, and I've done that multiple times using Bivalirudin. It works just fine. You don't get clot in the circuit. So I think it's slightly overstated, the worry about stasis with Bivalirudin. Equally, if you were really worried about it and you wanted to add some heparin, I think that would be very easy to do. You could give 50 units per kilo of heparin as a bolus, assuming the patient wasn't at any risk of bleeding, in conjunction with the Bivalirudin that you're on, just for the trial off. So I think there's ways around that, but I would encourage you all to try and get away from clamping people off if you don't need to.
Thank you. Any specific question in chat related to this before Dr. Peaks steps in?
There's a statement from Caroline Osment that I think is quite interesting. Maybe Dr. Peak and McMichael can speak to it. With babies, we continue flow through the circuit using a bridge, so we haven't had issues, but we have had a couple of cannulas clot off during the trial.
Well, this is exactly what the problem with the clamp trial is, and that describes exactly what the problem is. You do get clots in the cannula. If you have a very long segment above the bridge, it's a risk. And as you say, the circuit's protected by the flow around the bridge, but this is the absolute limitation of doing a clamp trial, and you don't have to do it. You can avoid it completely. This is what we used to do with heparin in the old days, before we described this technique. I think it's a problem with the technique rather than with the anticoagulant. I think avoiding it is a good thing.
Yeah, I think unless you have a contraindication to switching over to heparin, especially if you have a patient that you're going to be doing several clamp trials on, I'm thinking of a neonate who has a small arterial cannula, doing a heparin bolus of 25 to 50 units per kilo prior to the clamp trial, depending on their bleeding risk, I think is very reasonable. And then I think the other question is, if you feel like you're going to have to do several clamp trials before you feel comfortable coming off for whatever reason, then is it worthwhile switching to heparin for that 12 to 24-hour period, especially if you already have significant bleeding in the cannula? I think I unfortunately have had the experience of clotting off a neonatal arterial cannula on Bival, and that's not a fun experience. I think we've all had that at some point, probably even with heparin too, but I think thinking about doing a heparin bolus beforehand I haven't had any issues with clamping on Bival after doing that.
So can I ask you if you've ever used the retrograde technique?
I haven't, no.
No.
I'll bring that back to our center.
I have not had one single patient develop a clot in either the arterial or the venous cannula since I've been using that technique in over 10 years. but I have had clots in clamp trials with both heparin and not with bivalirudin, because I probably do it less now, so I guess the chances are less. But it's a fundamental risk with a clamp trial. So abolish the term clamp trial from your vocabulary and start using retrograde trial off. It seems a bit crazy, but it's really, really easy and it works really well.
I think we'll all be reaching out to you soon, so you can send us exactly how you do it.
We may have to have another webinar on the
Yeah, I think that'd be great. And you should invite Chris Harvey, the inventor of the technique, to come talk. But I'm really sorry I have to go, but this is a great meeting. Thank you very much for inviting me.
Thank you. We'll go back to our monitoring, but just to add, luckily I have been at different institutes which have tried different approaches to the clamp trial. So Dr. P used to do retrograde flow, which definitely has good results with bivalirudin, but my current center has moved away from heparin bolus and just does clamp trial on bivalirudin, and thankfully we haven't had to deal with a lot of clotting or complications, so that's a positive experience for us. So hopefully at some point when we publish our data for another objective, that would be good to share. We used to use heparin bolus, didn't have an issue with bleeding, but then since we didn't have an issue with clotting, we have moved away from the heparin bolus. We just flash our cannulas and just do our trial, thankfully, without any major complications so far. So going back to the questions we had about monitoring. So now, since this is the hot topic, a lot of centers have moved to bivalirudin. We are still figuring out which test to do, what frequency to use, which are the best validated tests. So wanted to ask Dr. McMichael, what is your thought? What is the typical protocol for lab monitoring for bivalirudin?
Yeah, so right now, most centers are using a PTT. I think some centers have the luxury of having a dilute thrombin time testing, and then maybe have some viscoelastic testing with either TEG or ROTEM. But the standard had been to do PTT as the lab monitor. And we can talk about the issues with, looking at PTT alone. But most protocols will do a PTT every 2 hours after a dose change. And then after you're at steady state, which I think is defined very differently. So our center is once you've had 6 hours at a steady state, then we monitor every 12 to 24 hours. So you can space out that lab versus I think most centers for heparin, for example, would get a 10A every 4 to 6 hours and then just continue that. So you do have to monitor PTT more frequently, and that's because of the half-life of bivalve being shorter. So anytime a dose change, check every 2, and then probably after about 3 or 4 PTTs within range, then you can go to checking it every 12 to 24 hours. I think dilute thrombin time is an exciting possible test. Previously it had been used more for research, and I think more centers have been able to convince their lab or transfusion medicine to bring it over, which is, I think, really great, because there are some studies that show that the dilute thrombin time has better correlation with the bivalirudin dose. And one of the things that is, seen in the literature about PTT is that at higher doses of bivalirudin, PTT does not have a linear correlation with bival. And so you can see that plateau state where you go up and up on your bival dose without any change in your PTT, which definitely can put you at risk for bleeding. Unfortunately, there's not a lot of data on viscoelastic testing in bival, and really trying to define what a goal R time for TEG or a goal clotting time for ROTEM should be. There's a few retrospective studies that have looked at correlation between PTT and clotting time, both in the INTEM and XTEM, or PTT and the R time on TEG, but really we're struggling to figure out what that true goal should be. But I think the rest of the viscoelastic testing is still great to monitor when you're on bival, to look at the MA, to make sure that your platelet function and quantity is enough, also to look at your fibrinogen as well. So I think there is still a role for viscoelastic testing while we're still trying to define what that goal time should be. So I don't think for right now it's a good titration for bival, but a nice additional monitoring, I should say.
Thank Thank you. Talking about direct thrombin time and additional monitoring, considering the test is not available in a lot of centers and it's not widely adopted, any opinion on what are the steps that are needed for this test to become more widely adopted?
Yeah, so I will tell you, in my previous institution and while we were doing the study, we didn't have a dilute thrombin time. And then we are working on getting it here at Phoenix Children's. I think part of it is the cost and then just lack of data. So now there have been some studies that have been published showing what a potential target for the dilute thrombin time should be relating to a PDT of 1.5 to 2.5 or 1.5 to 2 times normal. So there is some data out there for ECMO patients now. So I think that's a great way to try to convince your lab. And I think cost is the other thing. One way that we have tried to get around it, so maybe this will be helpful for other institutions, is we have a lot of VAD patients who are also on Bival. And so if you can, for example, I work exclusively in the PICU, but our CVICU is doing a lot of Bival for VAD. And so if we can kind of combine forces to show this is really how many patients that we have on Bival, not just our ECMO patients. Sometimes if you bring in the CT surgeons, I think they have a little bit, at least in my institutions, they've had a little bit more clout than sometimes the PICU does. So I think there's a need for it. I think we can all acknowledge that there's issues with the PTT testing. I don't know if you want me to talk about this now, but we know that PDT is affected by a lot of other things besides just our anticoagulation. So if you have hepatic insufficiency, if you have DIC, if you're significantly inflamed, that's all going to affect your PDT value and is really not going to be as helpful to titrate your bivalve. So I think we need an additional test to help us truly monitor bivalve effectively.
Thank you. That's an excellent point, especially for the institutes who are struggling to negotiate with hospital administration to get extra tests. And just a follow-up question. For the direct thrombin test, the standard test versus the calibrated assay, which one do you recommend more?
That's a good question. I was actually hoping Dr. Pete could answer some of this because I don't actually know between the two testing myself if there is one better than the other. I know there's some groups that will use what they call a Bivalirudin assay, but I don't know if we have enough research honestly to say which one is better than the other. Most of the studies I have seen is looking at a 1 to 10 TDT dilution.
Thank you. And I think there are questions in chat about this topic since this is a controversial topic. So I'll let Dr. Seitz take over.
Absolutely. One of the questions that came up, I believe you just answered, Dr. McMichael, thoughts on Bivalirudin levels. I believe your statement was simply just not enough data yet to support a Bival assay. I believe several questions related to PTT versus other testing, so DTT. Also, viscoelastic testing was mentioned, but you don't hold that as your standard. Please correct me if you disagree.
Mm-hmm. Yeah, I think that's right. I think the Seattle Center is really interesting because I know that when I was in Dallas, we sent labs over to Seattle to run for some of our patients who we thought they were likely within goal, but we were seeing that plateau effect with the PDT, and it was nice data to have. So I think we just need more information about the test out there so we can feel comfortable about which one to do. I'm not necessarily saying one is better than the other. I think we just don't know right now.
And another interesting question from Brenda Zachman. She had asked, have you seen a decrease in fibrinogen with Bival? And if so, do you treat it? On our neonatal patients, we have seen this.
Oh, interesting. I don't know that I have seen that. I think that's something I'll have to go back and look specifically at our neonates. Right now, our neonates on ECMO are done in the NICU and not in the PICU, so I don't see them as much as I used to. But not that I have seen previously. I mean, I think one thing with laboratory tests that we do know about Bival is the elevation in INR. And so I think that is something that can be difficult for centers when they're first starting to use Bival about knowing when to replace with product when your INR is elevated. But I haven't seen anything with fibrinogen personally.
Then I believe a final question related to lab monitoring from Leonardo Brandio. Forgive me, sir, if I mispronounced your name. Does the group have any experience using anti-2A for monitoring on bivalve? Thank you.
I don't personally, I mean, from what I have seen, this is mainly used for research purposes. So I don't know any centers that are doing it. I don't know if you guys have different opinions on that.
I have not seen anything in literature mentioning that people have been using it or have validated the test.
Mhm.
I think we didn't publish the lab in our paper, but we didn't see any changes with fibrinogen when we compared the groups. We did look at the data. Our neonates have done fine without it, but the INR can be once in a while a real big issue. I'm not sure if you have the same experience of having anecdotally one or two patients who have sky high INR, and if they have multi-organ dysfunction, it can be really hard to differentiate if we are dealing with liver failure or we are just seeing the drug.
Mhm. Yeah, I think that is a great point. And so, in general, I will tell our group to not transfuse FFP unless the INR is greater than 2 and is consistently greater than 2, and really to look more at the trend of INR than the actual number, because previously our protocol had been to give FFP to have the INR will be less than 2. And I think that on bivalve, we know that unless there are signs of clinical bleeding, and I think you can also use your tag or rotem to help you with this too. I don't think that we need to transfuse. This is a tangent, but I think this is Dr. Miguel Burgess also mentioned that at Arkansas they have the heparin or Hepzyme PTT. So removing heparin in the PTT sample. And so I think that is a really nice lab to have if your institution does it. It is more expensive than the standard PTT. But the nice thing is that if you have heparin anywhere in your system, you can remove it. So for example, if you've hep blocked one of your lines and you have some heparin contamination, you can look truly at just what the effect of bivalve is and not if there's any other heparin effect in the system. So there has been some studies that have shown that there's better correlation with the hep PTT with a bivalirudin dose than the PTT alone. And I think that was work out of Texas Children's with June's group. Yeah, so as someone is mentioning, they did paired samples drawing of the circuit versus drawing from the A line and found a 15-point difference. So they only draw the PDs off the circuit. And I think that's a great point. For bivalve, you really should be drawing your labs from the circuit itself and not from the patient, because so many times we have been giving heparin, into arterial lines for some period of time before they go on ECMO. So the PDT should come from the circuit. Our institution does a standard flushing of our lines, and I think Dr. Peak had a really great point about the circuitry itself. So forgive me if this is going off in too much of a tangent, but I think one of the things that we struggle with from center to center is how we put together our circuits and where we put our pigtails and how many pigtails we put in. And a lot of that has been affected from COVID and having supply chain issues and putting together random circuits with supplies that we have left. But I do think the more areas of low flow states, and I'm thinking, mainly pigtails that you put into your circuit, the more risk you are going to have for clotting and the more issues you're going to have on bivalve. So I can just tell you the circuit that we had in Dallas is very different from the circuit we have in Phoenix. And I can, at least my bias is I think we have less clotting when I look at our circuits here because of the less amount of pigtails that we have. I got us on a tangent, sorry.
Well, while we're pausing, Gabriella Centers asks an interesting question, citing a cardiac intensive care journal study. You can see that a snapshot of that study in the chat. She said this study found very poor correlation of regular PTT with bivalve's anti-coag effect, much worse than just caveats about using PTT. Is it reasonable at all to use regular PTTs for monitoring bivalve, given these results and other similar concerns? I'll say just personally, at a smaller ECMO center, I don't really have another choice. We do use bivalve on occasion. We use heparin preferentially, but occasionally we will use bivalve. We don't really have another option but to use PTTs. Thoughts, Dr. McMichael?
Yeah, I think, and I'll have to look at this study, but I think I would be really cautious to change your practice based off of one study alone, especially since all of the data that we have from bivalve, or I should say most of the data we have from bivalve is based off of PTT titration. So I would be a little bit worried to throw out PTT based off of this study alone. Yes, I think the point in the chat about saying that bivalve is more simple than heparin, I am glad that Dr. Peak thinks that way, and that's how it's been for him. I don't think it's necessarily more simple. I think the hope is that it's honestly better, but it does come with certain changes that your center has to make in order to run it successfully. And I think part of that is because you are checking labs every 2 hours versus every 4 hours, that really takes people at the bedside understanding that anytime we are making a dose change, that we're starting a clock and in 2 hours, we're drawing the next lab. And that next PTT is not in 3 hours and it's not in 3.5 hours or 4 hours. It really does need to be at 2 hours so that you can get to steady state, get to your goal anticoagulation quickly. I think you also have to have your ECMO specialist or perfusionist, whoever's sitting your pump, watching your pigtails closely, flushing them, making sure that things are patent, looking for clot burden. I don't think it's a set it and forget it anticoagulation. I don't think heparin is that either. I just am really hopeful that it's better, meaning less bleeding complications for our patients, which is really important at the end of the day, right? That's what we want to be doing. We know that bleeding and clotting are most common complications on ECMO. And so that's why we really want to try to find something better than what we're doing right now.
Thank you. I think the jury is still out and we still need a lot of more data to make that change. But considering the practice has moved faster than evidence, hopefully we'll have more studies out there which will help us refine the monitoring to have better answer. So the centers who have either moved to Bivalirudin or are considering moving to Bivalirudin, are there any special situations where you would not use bivalve?
Yeah, so
cautious?
for our study in Dallas, the one patients that we shied away from were the congenital diaphragmatic hernia patients. And I know some centers who have protocols for using bivalve for CDH patients, but I think that's someone that I'm uncomfortable using it for right now because I don't feel like our surgeons have equipoise. At least in Dallas, we had just had a protocol change to trying to do or I should say a guideline change to trying to do more early repair of CDH while on ECMO. And so we didn't feel like that was also a good time to introduce a completely new anticoagulant when we had a surgical practice change at the same time. So I think we need more data on what to do for the CDH patients. I think personally, I'm still nervous about using it in neonates with a small arterial cannula, especially ones that you are going to be doing lots of clamp trials on because of the risk of clotting. And then I think the other patients to really think about doing are the patients who have hepatic insufficiency, where their PTT is so prolonged that you're not able to use that as a good marker of your effectiveness of bivalve, unless you have an additional test like a dilute thrombin time to evaluate. I think you need additional testing that time. I don't shy away from patients with renal insufficiency or renal failure because I think we have enough data to know how to use it. And there's actually some interesting differences. I think the group out in WashU just published an interesting retrospective review looking at their patients on with renal failure and CRT showing no difference in dosing. But so I think renal failure is not an exclusion, but it's the hepatic insufficiency or failure patients that I think make it a little bit harder unless you have ancillary testing.
Thank you. So we did talk about renal failure and use of bivalirudin. Most of our population sometimes needs CRRT. So the patients that you have used CRRT with ECMO, how do you use bivalve in that? Do you run ECMO and CRRT both have different anticoagulation or just one infusion?
Yeah, so currently in my center, we do regional anticoagulation with citrate for the CRT circuit and then Bival to the patient. And I think that has worked really well. We have not had issues with the CRT circuit clotting. Previously, when I've done Bival only, I think we've seen more issues with clotting of the CRT circuit and having to change out more frequently. So I think regional anticoagulation works just fine, to be honest.
Just one more question. In your experience, when you have used Bivalirudin as the primary agent or the patients where you have probably switched them from heparin for any indication, have you noticed any differences in terms of outcomes?
I don't know globally if I could say a big statement in difference that I've noted. I think one difference in practice from changing from heparin to Bival is just being cognizant of the half-life of the two anticoagulants. So I think when you're thinking of stopping heparin and starting Bival, I think it's important to think about what the half-life of Bival is. So how long it's going to take you to get to steady state of Bival before just turning the heparin off. So I like to double run the anticoagulants, to be honest, to get Bival into the system before I completely turn heparin off. And usually it's because we have a patient and we're switching, it's because something is wrong, right? Maybe it's we're worried about HIP, but less likely or more likely it's not HIT. It's that we have, tons of circuit clotting and we're getting annoyed with heparin and we want to change, or we think we have heparin resistance. We're at 40 per kilo of heparin and we're not getting to goal. So something is going wrong. So you don't want to just completely get rid of heparin and then start at your low dose of Bival and spend the next 12 hours trying to get to goal. So I like to double run. And I think what makes people concerned is when you check that next PDT, I have seen people say like, oh no, my PDT is 100 now. I need to hold my Bival and go down on the dose. And I think that's not the right plan. I think you just stay steady and recheck again in 2 hours and then see where you are. And it's really the same when you're switching over. I think we all had hoped because of the Unblock study that looked at VTEs in pediatric patients and knowing that how Bival works, that it binds to not only free thrombin, but also clot-bound thrombin, that potentially Bival may be better in this setting of circuit clotting. So, if we had clots throughout the circuit, maybe we start Bival and they magically all go away. I don't think that I've really seen that in practice, but I think it's something that, it'd be interesting if someone could study the, and quantify the clots in there to see if it's actually better with Bival. I will say from a bleeding standpoint, I think when you're switching from heparin to Bival, that it's better. And I think that kind of goes with what we've seen in the literature, that there's potential benefit for using Bivalirudin in terms of bleeding, which usually has come out to be less red blood cell transfusions. I think the hard part when we're looking at all of these retrospective studies is that we're using different definitions of bleeding, and hopefully that's something that we can fix in the ECMO literature in general, is coming up with and using our standard definitions of bleeding and clotting, because it's really hard to compare these studies when we're not comparing apples to apples.
Thank you. That's very important. And just one more question about the use. When you run a transfusion of platelet or FFP, do you make dosing changes to Bivalirudin that time?
I don't during that time. We haven't done that for heparin either, so we don't make any changes to the infusion when we're running either platelet or FFP transfusions.
Thank you. We are lucky we have Dr. Enick with us also, who's our surprise guest. Thankfully, she's with us in this webinar. So I wanted to ask Dr. Enick if you would like to share your thoughts about the use of Bivalirudin and heparin. And I know you have so much experience, and we still are trying to collect the data on Bivalirudin. So things that make you cautious about the use, or your thoughts.
Yeah, well, thanks for inviting me. And sorry I'm late to the game. I had several other meetings, but I was the one who put the comment in that we maybe need to be cautious about saying we want too many tests. You get too many tests, you can get confused. I do think that we've confused our practice a little bit as we got new tests out, and then we could test for antithrombin, we all felt we had to replace antithrombin, but then we all stopped replacing antithrombin. And then we all felt very vetted that TEG and ROTEM were going to be the end all and be all to everything bleeding and ECMO considerations. And they are good and they are helpful, but I think I just would be judicious in the things that when we think about using it. I do think that, and I've said this before, I think that groups that have a very strong program where they have good protocols and can customize the care to the patient. So you have an initiating protocol and then you can customize it to that patient. And sometimes you need to change things and assess it a little differently. I think that that's, I think that's very, very important for us. And I think that's probably the biggest thing that we have to learn from any anticoagulant that we use. I think that, do I think Bival is superior or not? I think Ali has spoken to that very, very soundly to say, we really don't have anything that's proven it's better or not. I think the groups that are using it successfully should continue to use it. I think the groups that are using unfractionated heparin successfully should continue to use it. I think we do have to benchmark ourselves to the outcomes that we see and the bleeding that we see on ECMO, but I don't think it makes it a lesser program just because you haven't switched to Bival. I think if you're starting a program, you probably want to consider thinking about what your program does, the types of patients you support, and whether that's going to be something you can use. And I think that everyone has to have a protocol to use a direct thrombin inhibitor or alternate types of anticoagulant, maybe not even direct thrombin, maybe it'll be an antiplatelet agent in a couple of years. But I think whatever it is, we have to be amenable and flexible to be able to have those protocols as well and be confident. When I started, which is sort of dinosaur days back now, looking at it, the thing was that everyone was terrified. Everyone was going to bleed to death if we used a direct thrombin inhibitor, and we never ever used anything that would do that, or an antiplatelet agent. And we've come a long way. We've got smaller circuits, more compatible circuits, and we have more confidence in using these different agents. So my thought is, I always find these talks interesting. One is better than the other. But, if I look at what we do here at Sick Kids, which is an exemplary ECMO program that I'm very proud of, we use an unfractionated heparin, and we do an incredible job with all of our patients. And we don't have a lesser survival rate, and we don't have exsanguinating patients all over the place. So, and I think that that's for a lot of the big programs when I look at how many people are here. So I just would say that we need to learn from people like Ali and the groups that have switched and made a very successful switch. And there may be a time that we all decide when they no longer make unfractionated heparin or whatever happens, that we all will switch to something like that, or maybe a newer drug than Bival will come out that's even better, that doesn't stagnate in the pigtails, but still has a first order pharmacokinetics. So I guess that's just sort of my commentary on it, is to be careful what you wish for. We all just used ACT back in the day, and we said we were doing well. And then everyone gave us gazillion other tests, and then we all look at them, and I'm sure all of us can vouch for saying we test them every day. And do we really use each and every one of them? I don't know, but we do use it now more likely to customize our therapies and our anticoagulant therapy to that patient. And that's probably the biggest learning point I can say from all the monitoring we do. And I don't think one test is superior to another, and I don't know if we'll ever get there. So just my thoughts, but excellent session.
Yeah, I think that's a really great point, Gail. I mean, we have looked as a group at 10A versus ACT versus PT, which one is better, which one correlates better. And all anyone can find is that having a protocol is better than anything. And so I think it's the same thing with Bival. I think sometimes centers like it because we've gotten rid of having 4 tests a day. You just have your PTT, and we don't know what's going on with the rest of the patient, and we just have some nice little bit of ignorance. But I think it's really frustrating, especially for the bedside staff, when we're checking a 10A, an ACT, a PTT, and a TEG, and they're asking, which one are we supposed to be following? The PTT is high, the 10A is low. I don't know how to interpret the R time. The ACT is not correlated to anything. And so I mean, it would be great to have better lab testing to begin with, but I think I guess my hope is that, BioVal may be better and we need more studies to really figure that out. But hopefully in 10 years, we won't even be talking about this anymore because we'll have found a way to completely anticoagulate this circuit totally differently that doesn't have anything to do with a DTI or heparin.
Yeah, I agree with that. And I think, what we've learned at SickKids is we have Leo Brandeo, one of our hematology gurus at SickKids, and he's basically embedded in our ECMO program. So that thrombosis team is there every day. And what we do is we reevaluate what we follow that day. So we have that discussion on an ECMO round every single day about how things are going and are we happy with the numbers we have? And is there some specific number we should or shouldn't follow? And so that just sets the tone for the day, and you hope that the kid runs without throwing you a curveball, which they often do. But once they do, we're happy to then reevaluate. And we have that great collaboration. So I think that that's some of the strong points that we have to push when we look at those things. I thought that June Taria out of Texas was doing some kind of level for Bival or something. So, but maybe I'm wrong about that, or doing some of the anti-2A testing, but I could be wrong.
Thank you so much for sharing your insights. Wanting to circle back if there were any questions in the chat.
There are two questions, and kind of fun because one is very theoretical and one is very practical. So oldest question first, Naga Papala asks, some researchers quote anti-inflammatory benefits of DTIs. Any comments on this aspect?
I mean, I think at least Dr. Osment, when I was a fellow, always used to tell me that heparin was the dirty drug. And I think it's true, right? We know heparin binds to a lot of other plasma proteins. And Bival is, the theoretical benefit is it is a direct thrombin inhibitor. So it doesn't cause platelet activation, may not cause an inflammatory response. I don't know that we've seen it at the bedside to show that our patients are less inflamed, to be honest. But I think that is the hope, that it's maybe a little bit more steady, that you're not having binding to other plasma proteins, et cetera. And so maybe its effectiveness can continue to be steady. It looks like they are confirming that they do a Bival level at TCH.
And then another question from Carmen Giacomusi. Again, forgive me if I've mispronounced that. She states, I've heard of a few centers that pack their pressure lines with heparin and then don't aspirate Q12. Curious if others are doing the same, and if so, what's your technique? She goes on to cite that they have some limitations with this due to the number of pigtails that they have.
Yeah, so we flush our lines I'll have to double check with our specialist. I think it's either every 4 or every 6 hours. So they aspirate back 1 to 2 mLs and then they flush with 2 cc's to completely clear the line. I don't know about packing with heparin and then leaving it alone. I'd be curious if anyone else out there has done that. I think it is true though, and that's, partly when we're talking about using Bival and it being simple, this is something you have to be thinking about too. This is a lot of extra work that you're asking the bedside specialist to be doing to flushing their lines.
Do we have time for one more question? I'm getting the nod. All right. Question
Yes.
from Naga Papala for Dr. Inich. My question is regarding antithrombin 3 with heparin. What are the thresholds now that you use at SickKids for AT3 replacement?
Well, I can say that we probably don't use a threshold as much as we look whether we've got response to heparin, and if we've got a reasonable response and we're within a good range, we'll look at the anti-3 level thrombin 3 level, but we don't necessarily replace it. If the patient is stable and the anticoagulation is working well, we'll just continue to follow it. So we don't really have a threshold where we do an automatic replacement. It's incredibly rare that we give antithrombin, very rare.
Thank you, Ellie. Thank you, Gail, for joining us. And just a reminder, you can use the QRS code for the evaluation for the webinar, and remember to send your code for the CME credit.
Thank you so much for having me. Thanks for
Yes,
having on,
really.
Gail. It's good to see you.
Yes, really appreciate everybody joining us so much. Just to let everybody know, this is going to be, the recording is actually going to be posted on our YouTube channel. And in a couple of days, we'll get it up, and that has all of our recordings from our past webinars as well too. But thanks everybody for joining us. We appreciate it. And thanks to our panelists.